Okay, thank you very much, Stephen, and welcome to everyone who has just joined us. It's really a pleasure for me to step in the big shoes that Rory has left for us today, but I'm really pleased to introduce Ivy Muya, who is our speaker today. I've known Ivy for a few years now. She may not know. She's really a star. She's a leader in emergency nursing field in Africa, and she's been championing a nursing mentorship program, a nursing group for African emergency care. She has been in Kenya, she's been in DRC where she's working now. Initially, she was working for the Ebola response, but apparently she's now involved in the COVID-19 response as well. So it's a pleasure for me to be introducing this nurse. Nurses are the pillar of the health system in Africa, as you know. And as doctors, we know that without them, there's no way we can practice medicine. It's really a pleasure today to share that experience that that Heidi has with the rest of us. And without further delay, I will hand over to her. Perfectly. Go ahead, Rory. Ivy, thanks.
Yeah, you can call me Rory as well. No worries. Okay, good afternoon, everybody. As Ken has said, my name is Ivy Muya. I'm Kenyan. I'm an emergency nurse, but I like to think of myself as a mentor and also into it all. I'm a member of Emergency Medicine Foundation, WHO team that was responding to Ebola. And as we were here trying to demobilize and in COVID, so we're supporting all healthcare workers who are actually on the front lines. So we'll just jump right into, that's the Congo. So today's discussion is about Kenya, but I was asked to mention a little bit about the scenario here. That's the map of Congo. What it's important for you to know is to see our proximity. As you can see, it has almost 9 bordering countries. Closest to us in Kenya being Uganda. We border with Uganda and Tanzania. And this is a quick overview of where COVID is now. I'll direct your attention to where it says 6,950. I'll give you the updates in the next slide, but just to show you how the spread is over Congo, the darkest color of red means where there are the most cases, and the lighter colors, as the hue reduces, shows where the different cases are. It's a very huge country, so we're having multiple issues here because we have a second outbreak of Ebola. If I take you back to the map, you see there is the Central African Republic. Around that area, there's a town called Bandaka. And now we have a second outbreak of Ebola in that region. So it's a very complex issue right now. Real quick statistics. Since it was declared on the 10th of March, as of yesterday, because we get figures daily, the number of confirmed cases is 9,000, approximately 9,500. The deaths are approximately in the 200s, and survivors at least are in the 8,000s, which is a good thing. But the majority of the cases are in Kinshasa. So I'll take you back so that you understand this. You do see Kinshasa is on the left of the map, the left lower side, what we would say the southwest, more of the southwestern cases. Why? Because when the outbreak took place of COVID, they had not yet shut down the countries. There's lots of direct flights coming from Europe. And this is exactly why it's found in Kinshasa. Are not published. So of interest, this is what we get as people here on the front line on a daily because we have to monitor. I was also asked to talk about a little bit about COVID and Ebola simultaneously in the same country. What are the differences? I just divided it very simply in a way that you can understand. So the only change between PPE, COVID, as far as PPE, from the point of view of socially, public awareness, hand washing was there already points when there was Ebola in every single part of the country, especially in the north where the outbreak was. And hand washing still goes on now because, as you know, it's still required in COVID. Now, social distancing in Ebola was not as exaggerated. For example, we didn't really have to walk meter to meter with mandatory social distances. Public awareness, it had a bit. See, the outbreak took a very long time to control. So back to the public awareness. So with COVID, when COVID came and was declared an outbreak in March, remember already the society, the community here had dealt with Ebola for about a year and a half. And there's a perceived fatigue, like, oh, so we had Ebola, now we have COVID, what's new? Or, tell us something else. But there is still an element of precautionary measures that are still in place. Response for Ebola was primarily international by the WHO, but for COVID-19, it's the Ministry of Health, the national government is the one responding to the outbreak. Let's go back to the Kenyan situation, and this is going to be more of a discussion because the last time I was home was about almost 6 months ago. So we have 50% of nurses make up the global workforce. So we do all know that we're very in healthcare. What does it mean in the times of COVID? WHO made some recommendations to different governments and ministries to support nurses in the front lines. And this is going to be the crux of our discussion today in the Q&A session, because there's lots and lots of things probably happening in Kenya that I'm aware of, but frontliners would be best to support this or to make comments. I picked up some excerpts from WhatsApp conversations between nurses and nurse groups. And I picked up comments like, it has made me scared, or COVID is a baffled science, or it has compromised social events. All these are tidbits of things that really, really affect the approach of how nurses and others actually see this disease. I picked up another one where Nurse X said the curve has started to flatten. And then Nurse Y asked, is it really flattening? And here comes Nurse Z, the scientist. Where is the evidence to suggest this? And back to Nurse X, who then says, I said the curve has started to flatten. You shall see the real picture in a few weeks. Which got me thinking, are we doing any nursing research on the situation right now, be it educational, informational, qualitative, quantitative, perceptions, psychological, psychosocial, clinical? There's so many aspects of research that nurses can get into, but I'm not very sure whether we're engaging enough. I put this picture to talk about social distancing. I have my colleague, who I didn't ask for permission, but he's seated across me. He wasn't well during these times. And I had to ask myself about the social distancing of COVID, which is something that nurses go through when you're with patients. There is a healing power of touch. It's not scientific, but it is there. When you have patients in the ward, when you have patients in the ambulance, just touching them gives them a sense of comfort. And it was his birthday and he was really unwell. But we had to try and balance the situation just to give him some hope as we were here in our little emergency trauma room. So are we still able to give holistic care to our patients? Or are we so scared that there's COVID that we might not even want to get as close to them, even as we use our PPE? There's a professionalism, of course. You have to use infection control protocols. So I wouldn't expect people to just be taking care of managing clinically these patients and actually things go back to the way they were before COVID. We shall go into credible sources based on the fact that there's a lot out there being discussed about COVID, but you need to be very, very careful where you're getting your information from. There's lots on social media, there's lots of stakeholders giving information, but this is for a competitive advantage. Political figures, well, we all know some people might use their authority to shift the curve or to shift the focus. And of course, there's media networks. Now, every time when you think about this, you need to think about who best would provide latest and more credible information, and how would I know the information which is credible? How would I know what to believe? So, in my view, and a few more views, some of the sources you can go to is none but our own Emergency Kenya Foundation. They have lots and lots of information about COVID and other things. Their algorithms. There's a WhatsApp group for questions. You can post a lot of stuff. You can read a lot. Has been critically appraised. Another source, of course, is WHO. There's lots of bulletins, guidelines, and advice. WHO advises and guides and recommends, but it never enforces or forces anybody to do anything. There are also open online courses being offered by WHO. All you have to do is register. It's now, I think, in 11 languages. So it's easy to do. Just register, go through the content, go through the assessment, and there are certificates, because I know lots of people love certificates. We have some websites like Medscape. From time to time, I do use this to get a light reading. Depending on your school of thought, I think this is a very credible source as well, but others may choose to use other sources. And there are many others which we can discuss during this forum. Last but not least, the reason why we have these AFEM webinars is because Africa Federation of Emergency Medicine is a forum where problems in Africa, solutions in Africa. In this forum, we do have a website, and in the resources section, you will find a nursing section. We have a mentor-mentee program known as GENMA. In this program, we encourage people to register as as mentors or mentees. What does this do? Anytime you have a very pressing nursing issue that you want to address, we're able to, once you log in and once we know who you are and you register, we are actually very able to guide you or to actually link you to a mentor, or if you're a mentor and you're looking to mentor a mentee, this is one of the avenues that you can use. We've developed a couple of resources, so I do encourage everybody after this, because we don't get a lot of people registering or trying to find out what's really happening out there in Africa as far as emergency medicine is concerned. And with COVID, with the exception of treatment centers, some of the first places where the COVID patients are brought in are in the emergency room. So this is actually a very good resource that you can all use and put it out there. And last but not least, please remember, it is the year of the nurse. We should be proud of all our achievements. We should be ready to share. We should be ready to discuss. And of course, we should be proud and very proud of our frontline heroes battling with COVID out there. I guess we can move to question and answer sessions. Thank you.
Thank you very much, Ivy, for this brilliant presentation. Thank you very much. I think we will.
Thank you. Thank you, Ken.
Yes, Rory. I was saying thank you very much, Ivy, for the brilliant presentation and happening years here in Kenya. I think we will take questions. There are a few points that have been posted, I think, by Stephen in the chat. I don't know if everyone can have access in the Q&A section or in the chat. There are a few points that we thought bring us. Thank you very much. We really want to apologize for the technical challenges today. Hopefully you will sort it. One of the aspects basically I wanted us to discuss on, and maybe Ivy to touch on, if there is no comment or question from the participants, of nurses being infected nurses being great in average for monthly. I don't know if you see delivery, what kind of health delivery in the region where you are, Ivy, and what's the
So so remember guys, I'm in the DRC, but I do see some of my attendees, some of my classmates, and who can give me very good insight. Lucy Mengani and Lucy Njue, I can see you there. Can you unmute your mics and just share with us what's currently happening in Kenya right now? Lucy, I see you've muted your mic. Can you unmute it and share a little bit of experience in Kenya? Or other Kenyan nurses, I can see John Otieno, and there's the other Lucy. Please go ahead and share because you're closer to home than I am. All right. As we wait for them to unmute, at the beginning of the outbreak, there was a lot of health professionals had to actually buy these PPEs, the masks, as a commercial enterprise. And all these were teething problems at the beginning. As time went by, the government started putting systems in place. It has been purported that some counties are not able to support critical care patients, as we have 47 to 49 counties in the country. The specifics of which counties are readily equipped and which ones do not can be obtained through bulletins from the Ministry of Health in Kenya. As far as I know, the current situation is we have cases rising as we speak. We're still under restriction levels, and we had been put on social amenity curfew stroke lockdown hours. Now, when it comes to the hospital setting, the frontliners would know this best. Depending on which hospital setting you are in, public or private, is a determinant of how well you'll be able to safeguard yourself actually from contamination or infection. So, like I said, it's not a unique problem. Pretty sure in most of Africa, especially with these webinars, from what I've heard, at the beginning, there were teething problems. But now we seem to be just getting by and just getting to understand the actual situation with the COVID outbreak. Over to you, Ken or Steve.
Yes, I will try. And thank you very much, Ivy. I don't know if my voice is clearer than it was before. Can you hear me?
Yes.
Yes. Yes, thank you very much for sharing that experience, Ivy, although you are far from home. But as you said, nurses can relate either here in South Africa, in most areas in Africa, and the news that the challenges have been the same, and with time, there has been improvements. I wish, yes, a mention you have, but in nursing, one of the things that is that the nurses are not what would be the key to how experience the approach you are having to try and get IV?
Wow, Ken, that's a tough one. Yes.
Yes, go ahead.
Nursing involvement in research has its challenges. Research in itself, in any cadre, whether it's doctors or nurses, especially in Africa, it's something that requires a lot of mentorship. There are resource constraints like time, funding, the knowledge and the know-how on how to conduct research in itself. We've tried with the African Federation of Emergency Medicine to encourage people to engage in research, and we've put a lot of resources on the website. And also we've put a lot of emphasis for practitioners to publish in the so to speak, research is built on interest. It's not something that you can force down anybody's throat. The baby steps that I encourage nurses to participate in is to be part of research by at least being research assistants. before even just jumping straight into doing research, because it can be very difficult. I've done it, I've tried it, and I still do it. I'm published, but it was very difficult, and I needed a lot of mentors. Based on this, I share my experience to other nurses and say, please join me. I can hold your hand. You can hold mine as well, and we can go through this journey together. What I'm not sure of in Africa is whether we've cultivated enough interest to want to carry out research, or is it something that we've left for other cadres to do, or other professionals to carry out for us, but it is in our field. There are research published out there by nurses, but in Africa it's a very minimal amount. It comes with the first thing is interest, and especially now when you have COVID, I would really encourage the nurses in Kenya. This is the time to actually collect information and put it out there and get some help. And we're here, we're ready to help anyone who's interested in putting out a study, especially in these times of COVID. There can never be enough information put out there when it comes to science and the management of an outbreak or pandemic such as COVID. Over to you, Ken or Stephen or Swasti.
Thank you very much, Ivy. Yeah, Swasti?
Hi there, Avi. I was just wondering, in your experience, do you think that nurses have the access to mental health support that they need, that they have the sick leave and the insurance as well that they need? And I'd like some of our attendees to please step in and talk about this. I know that we have Debota from Nigeria. I'm not sure if she's a nurse or not, but perhaps she could give us a perspective on how things are going in Nigeria as well.
Yeah, I'm not a nurse. I'm an emergency physician. I'm a doctor.
Thank you, Debota. Sorry, I wouldn't know what your cadre is, but as an emergency physician, how are things going in Nigeria, and how do you think the nursing support is going in Nigeria as well?
In the hospital, because of this COVID, there are task forces and teams, alert teams for the COVID. So if any nurse or any doctor, any health worker has any problems, especially symptoms of COVID, the person reports to the task force. They will examine the patient, and if the patient needs to be the person needs to be admitted, he or she is admitted. If there is need for self-isolation or quarantine, is done, and the person is also given sick leave.
Okay. So Ivy, in your experience, do you think nurses are given the mental health support and sick leave and insurance that they require? I know that's a sweeping statement, but I think you have quite a bit of experience in the nursing field and maybe could direct us a little.
Wow. I have to be very careful. The answer to this question I'm going to give based on my perception and the knowledge that I have of what usually happens. So, say for example, you have an outbreak, and now this is a pandemic. There are recommendations that nurses in the front line should be given a lot of help financially, sick leave, mental health, counseling, time to reunite with their family. Talk about my own experience. We work on a 6 weeks on, 6 weeks off schedule. I came in February, so I thought that I would be home by April. COVID hit in March, country went under lockdown, airports closed. My role as a nurse, like any other nurse in any other part of the world, specifically in Africa, there's a lot that's demanded of you. You are not expected to be tired. You are not expected to be burnt out. You're expected to be good and to care. What I see, institutions provide counseling sessions. Proactive counselors come physically looking for specific nurses to sit down and have a chat with them, whether it's individual or group counseling. Talking to each other, colleague by colleague, just by talking, is one way of coping, called just letting it out. When we were here, remember earlier I was asked to talk about Ebola and COVID. Remember already, most of the team was burnt out, had been responding to Ebola, and we were coming to an end in April. And then came COVID, and then came the second outbreak of Ebola. Some people had been asked to respond. Actually, most people were asked to respond. And it's not more like you're being asked, more like you're being told. Of course, you can choose, to decline, but then you know what's going to happen to your source of paycheck every month. So as much as nurses are in the front line, sometimes you don't feel, there's a perception of support, but you don't individually feel it because there's too much expected from you. And every time in any part of Africa or the world, when you choose to take on an assignment, when you choose to come on mission here, like in the Congo, and you're in areas, which is why we can't help but call ourselves frontline heroes, because you see everything and everything comes to you at first. So from government to government, I would not want to make a comment. It's on individual governments and ministries of health that should be supporting the frontline workers, whether it's monetary, directly or indirectly, whether it's monetary, whether it's by giving social amenities, awards, recognition, time off. It's a very tricky and a very catch-22 situation. Over to you, Swati.
Thank you very much, Ivy, for that insight, and then knowing exactly where you are working at the moment and what Ebola means and what COVID response in the Congo means. I can definitely relate and say how heroic your presence there is. It's not easy. Most of that it was not planned, and it's just happened. It fell on you, but you are resilient and trying to do the best you can. And that's is probably the case in most areas in Africa, where the nurses generally give more, and we keep on asking them. I don't know if there's any participant who has a question or a comment along those lines, and who can unmute his microphone. Can anyone comment or any question in the chat or in the Q&A section?
Actually, I have a little bit of a question or comment to both Ivy and you, Ken. Ken, you are from the DRC, and Ivy, you're currently there. Do you think that the perspective or having had Ebola as an epidemic in the Congo many times in the past and currently now has in some way prepared you a little, or the country a little bit better for the COVID pandemic? And I ask that because it doesn't seem like COVID's going away anytime soon, unfortunately. And, it's a message of hope that although COVID has disturbed and uprooted our lives to such an extent, the message of hope is that because we have this experience, we may also be a little bit more prepared for future pandemic or for the resurgence of COVID if it should happen again.
Yes, I can give my take on that before Ivy, who is on the ground, can complete my point. I think there has been a lot of progress. I mean, there has been a lot of lessons learned. And remember, there has been like 10, if not 11th outbreak of Ebola over the past 40 years in Congo. They have been in rural areas most of the time, and the last one we had that has been declared over by WHO recently in the northern part of the country, in the northeast side of the country, is the one that affected with the biggest and affected the more urban area. It's always challenging. The same problem are recurring, like community sensitization. The perception and attitude of communities are always a challenge. Communication from the government has always been a challenge. And in terms of response, most of them have been controlled relatively quickly in the past, with few number of deaths, considering the challenges in infrastructure and the programs that are running in the DRC. So relatively quickly, they managed to control it. And the expertise from microbiologists, public health is growing, I would say. I mean, most of the tests, for example, are being run back home, and they are quite eminent leaders like Professor Muya, who have over time managed to get the government to define clear policy. But what I will say from my experience, having been there when the first case of the coronavirus was announced in March, I was in Kinshasa by then, I think there are still a lot of challenges. As much as a lot of points have learned and a lot of improvement is made, the challenges are just so huge. And it's quite multifactorial. I don't think it's only related to health issues, but it's basically the situation of poverty, infrastructure, the programs that are running that makes any response when it comes to Ebola quite challenging. But as Ivy has said, I think things like hand washing, things like community understanding that there's an outbreak and how to relate with health professionals and cooperate, that has been a gain from what happened with Ebola previously. So in a nutshell, that's what my take is. As much as there has been a lot of improvement, a lot of lessons learned, the challenges are just huge, just due to the poverty situation in the country, the distances and the infrastructure. There's still a lot to be done and to make sure that these outbreaks are better managed. I don't know if Ivy has a better view from the ground where she is.
I can only reiterate what you've said. Plus, we all remember COVID. This COVID virus has become a mystery, and we all can't 100% know what the future of this COVID is going to be. What we know is what we've seen. And what we've seen is what we're trying out and what we're testing. So my greatest fears for this country, especially in this area where I am, which is called North Kivu, is we have no capacity at all to take any critical care patients. Most of the teams in humanitarian missions probably would have to be medevac out of the country, or the closest would be to Kinshasa. But then again, that's where most of the cases are. Just recently in Goma, where all tests were being sent from the North Kivu side, they ran out of the PCR test. The government doesn't accept the rapid test. So it's, Ken is saying, there's a lot of challenges. It's a very complex environment. And the response to this pandemic here is being conducted by the national government and the Ministry of Health, who have their own way of doing things. So it's not easy. It's not easy at all, even for us who are here as nurses and frontline workers, even doctors. It's not easy. We barely went through Ebola, and now it becomes another challenge. But lessons will be learned. As Swasi has said, this COVID doesn't seem to be going anywhere anytime soon, but it is what it is. We'll just continue to support. Over to you, Swasi.
Thanks for that, Ivy. I was just wondering, do you have any advice? And I'm not sure how on the ground you are in terms of your nursing care, but would you have any advice to offer about how to take vitals, or how taking vital signs as a nurse has been adapted in this time of COVID? Is that your current practice?
Not really. I would hope the participants would make a comment on that or would share, as I'm not particularly in the front line. But I would imagine the same precautions of taking vital signs. Lucy is saying something. The same precautions that were taken with Ebola, even when it comes to taking vital signs, would be perhaps the same as those of COVID. But I'm not on the front line, but I would imagine it should be the same. Nothing would change. You're still with your PPE, donning off, donning on, ICP, infection control measures, and the likes. So unless there's something specific about vital signs that any one of the participants would want to make a comment on.
Well, maybe I could say something on that. AFM is coming out with clinical guidelines, and I'm not sure if it's actually on the resources page that you alluded to already. Maybe Ken can send that off to Steve if the resources with the resources page link, and we can put it up on the chat. But AFM actually recommends that obviously we still need to do triage, and triage is essential. And across the world, triage is usually done by nurses. And that's why I think it's relevant in this webinar. But one of the things is to emphasize the taking of respiratory rates and oxygen saturations, and that if possible, to have the no-touch thermometers, which would be quite useful in terms of infection control, and to remember to disinfect the saturation probes after every patient use. And AFM actually also recommends the proxy measurements of blood pressure. And by that we mean that to assess the character and the volume and the rate of the pulse instead of actually performing blood pressure. The reason is that blood pressure cuffs would need to be sanitized after every patient use as well. So currently in the Western Cape, for particularly COVID patients, and I'm not saying this for general patients, but once you've screened a patient and the patient is likely to have COVID on your screening, unless the patient has a history of hypertension, or obviously if you suspect that the patient has a low blood pressure, then to take a blood pressure measurement. But otherwise, if the patient has a good volume pulse that isn't tachycardic, then perhaps we should think about using that as a proxy measurement of blood pressure. What are your thoughts on that?
On this front, I use thermal guns since forever, of course, because of Ebola. And but for BP, I guess in the age of COVID, that is definitely something that we would want to recommend to the facilities here, as blood pressure usually is taken with a blood pressure cuff. The saturations monitoring is not as common, but when we come to think about the probes, because we don't have the public facilities, there are not that many monitors or even none. So for the bulk of the facilities which are public, people, yes, have been taking blood pressure by proxy. But yes, that's a very useful comment, especially with AFM. If AFM is championing that and encouraging that, that's something that we would definitely want to recommend the nurses to be very careful about that, as to how they take vital signs into practice. So I see Lucy did, I'm just going to go back and say Lucy did make a comment here on the chat and mentioned that two things. One, for mental health support, there is a support center, which is based at the Nurses Association Center, which is a good thing in Kenya. And I sort of see another chat she's just posted saying there's lots and lots of healthcare workers, especially nurses, who are actually facing comorbidities or getting infected. And that's something that probably that should be in another webinar. Frontline workers are also facing lots and lots of, they're at risk. They face a lot of risks based on maybe shortage of PPE, or the fact that you can pick it up in hospital or you can pick it up out of the hospital. And that's something I was discussing this morning with somebody about shift work and changing the way shifts are done. So if you have a whole shift, probably say even 30 nurses coming in and out every day, probably nursing for COVID cases, 100% effectiveness. But when you leave the hospital, You're not 100% fully aware of who you're in contact with. You could easily spread it or be contaminated and bring it back to the hospital, which means then again, you will spread it amongst your colleagues at the hospital. That's a whole nother webinar that somebody should look into, looking at shift work. So you can have like nurses coming in for half of the month and staying within the hospital quarters or a designated area that is set up. And after half the month is done or after 2 weeks, the shift changes. This improves on your contact tracing as well, and also tends to reduce movement of nurses coming in and out, even doctors as well. Because once you have people coming in, then they use public transport, then they get home, and they come back, and then, you know, so it becomes like a vicious cycle. But I mean, those are my thoughts. Somebody needs to look into that or talk about that as well. Over to you, Swati.
Yeah, Ivy, I know that in a few other countries as well, doctors and nurses have actually chosen to stay within hospital premises if that facility is available, especially in terms of protecting their families. Others have, you know, stayed in hotels. I think during the New York epidemic, certain hotels, because they were all essentially closed anyway, opened their rooms to healthcare workers. And people just simply commuted privately back and forth from there. So, I mean, it is something to look at, but I think it is also quite an investment in terms of resources as well. Yeah, but thank you so much, Ivy. I really appreciate your presentation. I appreciate the viewpoint of a nurse in Africa. It's always something that is welcome. I would love to get more nurse engagement in our AFM webinars going forward. But thank you so much for your presentation. And if there isn't any further comments or questions, perhaps we can close there.
Yes, thank you. Thank you for having me. And thank you, Ken. Thank you, Stephen. And thank you, Swati. Thank you very much. And of course, to all the participants for listening in, thank you.
Okay, thank you very much again, Ivy. It doesn't seem like there are any other questions or comments. So I think we could close on time for once. Thanks again. Bye-bye.
Ivy, bye.